All right, guys, welcome to CE Solutions. My name is Luke Brennan. Thank you guys for using CE Solutions for your continuing education needs. I hope that this lecture is very helpful for you guys today. So today we're going to be talking about the pre-hospital care of pediatric cardiac arrest patients. And we know this is a topic that is a difficult one, right? We know that from an emotional standpoint, these are going to be scenes and situations that are very highly emotionally charged for the family as well for us as EMS providers. And also it's one of those situations that we don't see very often in the pre-hospital environment. We don't very commonly go on pediatric cardiac arrest. And so when we do, it's going to be one of those situations that I think inherently is going to, give us a little bit of a catecholamine dump, right? We're going to get some of our adrenaline going and it's going to make us a little bit nervous, right? But I think that's why it's super important for us to know it very well. That way when we show up, we know exactly what we're doing and we can provide the best care possible for these patients. And we're going to see that statistically the outcomes for these patients is usually not good, right? Statistically, usually these patients do not make it. And that's the harsh reality of the situation. But we as providers, as medical providers for these patients, we want to show up and we want to be able to provide the best care possible for this patient to make a recovery. Now, with that being said, we also need to have a understanding that, okay, these situations don't always end well. And so just because we don't always walk away with the patient with a pulse back, right? We can say, okay, we showed up on the scene, we handled it professionally, we did everything we were supposed to do for this patient, we gave him the best chance of survival, and we can live with the result. Okay, so as we talk about pediatric cardiac arrest, we're going to go through some points that are important for us to understand as we treat these patients. We're going to talk about some of the anatomical differences for these patients. We're going to talk about what are some of the most common causes that pediatrics go into cardiac arrest. Then from there, we're going to talk about our treatment aspects of it. We're going to talk about our algorithm, our pediatric cardiac arrest algorithm. We're going to talk about how to calculate those drug dosages, your equipment sizes, everything like that. We're going to talk about some of the specifics of airway management in these pediatrics, some of the differences in cardiac arrest management between pediatric patient and adult patient. Then we're going to talk about, okay, if we do get ROSC on this patient, how are we going to manage it for these patients? Then I'm hoping also to get my hands on a pediatric dummy as well as some training equipment, and hopefully do a simulated scenario for you guys so you can kind of see a live action example of how a pediatric cardiac arrest should run. All right, guys, let's get into module 1 as we talk about pediatrics and some of their anatomical differences. All right, guys, let's go and talk about some of the anatomical differences that we see in pediatric populations in comparison to our adult populations. So number 1, let's start at the head. So we know that young children, especially infants and newborns, are going to have very large head in proportion to their body. So even kind of the statistic on that is your young kids are going to have a head size or a cranial size that is about 2/3 of the size of what it will be when they're an adult. We know that the rest of their body is not that big. And so their head in proportion to the rest of their body is much larger than in proportion for an adult. So where that's going to be applicable for us is one, in trauma or injury patterns. These patients are prone to be top heavy. So if they fall off a ledge or experience some sort of fall, they often land on their head due to having the most amount of weight and the large size of their head. For us too, as well, when it comes to EMS provision of care, a couple considerations is if we're trying to keep these patients in a good neutral position, especially if there's C-spine considerations, we're going to want to consider padding under their shoulders to keep them in just that good neutral position. As well as if we're hoping to do airway management on this patient, then what we need to do is consider padding under the occiput region of their brain or up their skull. That way we can get them in a good sniffing position, optimize their positioning for airway management. Another consideration is our fontanelles. So we know that our newborns have fontanelles, right? Kind of assists them coming through the birth canal. And the fontanelles are the region of our skull that, we have each of our plates of the skull come together. It's the area where it all fuses together and becomes solid. So for our patients, usually 2 and under, they're going to have these fontanelles that are not fully fused, and they can tell us some things about the presentation. So we do have our posterior fontanelles and our anterior fontanelles. Typically the posteriors are going to be fully fused after about 4 months after birth, whereas our anterior fontanelles will be about 2 years after birth. When it comes to assessing our fontanelles, they can actually tell us quite a bit about what's going on with our patient. If we have normal fontanelles, that's great, but we can usually, if we have a disease process, we may see bulging fontanelles or we could see sunken fontanelles. And what that's going to clue us into, now it doesn't always mean that this is for sure the diagnosis, but it's something that should cue us into looking deeper into, is this what's actually causing it? So if we have bulging fontanelles, so that'd be if you assess the fontanelles and they're really, a lot of pressure in them, kind of bulging out, then something that should cue you into is there's a potential that your patient has increased ICP. That makes sense, right? If you have lots of pressure inside that cranial vault, and then you have these fontanelles, which are kind of the soft spot for these young patients, there's gonna be a lot of pressure there, and it can kind of make it bulge out. Okay, so that should clue us into maybe there's something going on, intracranial hemorrhage, something else causing increased ICP, and we should assess further to confirm our findings on that. Again, if we have sunken fontanelles, what that is typically going to be cueing us into is dehydration. So a patient who's either hypovolemic and dehydrated because there's not as much fluid volume being sunken in, and that should cue us into maybe this patient needs some fluid resuscitation, maybe they're dehydrated, and just help our assessment cue into those, and then hopefully have the appropriate treatments after that. Okay, so that's our head and fontanelles. When we come down to our neck and airway, this is a section that's very applicable to us as paramedics, because when we're managing these pediatric patients, especially talking about a pediatric cardiac arrest scenario, airway management is going to be very crucial for these patients. Now, a few things that's going to make airway management a little bit difficult for these pediatric patients is going to be their anatomical differences. So one anatomical difference is going to be a shorter neck in comparison to the rest of their body. We know that even for adult patients, right? If we have patients like short neck, small mouth, limited neck mobility, things like that, it's going to be a patient that's a little bit harder to manage their airway. So with these patients, pediatric patients, just anatomically already, they're going to typically have a shorter neck, which can already make it a little bit harder to manage their airway. That along with they have very narrow airways. So if we're just talking about passing a tube, right, it's going to be harder you're going to be more precise to get it through. As well as when we talk about disease processes, if we have, a small lumen, if this is their airway, like if this is an adult airway, this is a pediatric airway. An adult airway, if we have a little bit of swelling, we're still going to have a good amount of space for that airway to come through, right? For the air to pass through the airway. But if we have a pediatric airway, which is already much more narrow, and we get that swelling, then it exponentially makes it smaller than it does in an adult patient, can more quickly lead to respiratory distress and difficulty getting good ventilations. Okay, so that's something we need to be aware of, is that because their airways are narrow, any small amount of swelling, things like that, can cause larger effects for these patients than it would normally do for an adult. A couple other things too is these patients do have a big floppy epiglottis in comparison to adults. So this is why typically when we talk about airway management, we're going to be going with a Miller blade, trying to move that epiglottis up and out of the way, and that way we can visualize the cords, because sometimes that epiglottis can be very floppy and very big and can obscure your view to the cords. One more thing that's very important for us is to know that these patients, because they have such narrow airways and because they're often nose breathers, they are very susceptible to mucus. Even just small mucus plugs can cause significant effects to these patients and can really cause some respiratory distress. So that's something we should always be thinking about when we come up on a pediatric patient who is having difficulty breathing. Is there any sort of mucus plug or secretions that are making it difficult for air to pass through their airways? And in those cases, if that is a suspicion, pulling out a bulb syringe suction device or an appropriately sized French catheter suction device and suctioning their nose and mouth can be very helpful. Okay, a couple other things. So respiratory system, this kind of goes with what we were just talking about. When we talk about the differences we have in pediatrics compared to adults, in comparison, their tidal volume is going to be less proportionally to an adult. Okay, so the amount of air you move in as an adult compared to your body weight or your ideal body weight, for these patients, for pediatric patients, can be a little bit less. And then that in consideration with their O2 demand, their oxygen demand is actually doubled. Okay, so we see that O2 demand for these pediatric patients is going to be twice as it is for an adult. So they're very dependent on good ventilation and good oxygenation. If something goes wrong, then hypoxia, they can quickly become hypoxic, and that can quickly cause deterioration of pediatric patients. In fact, that's one of the most common causes of cardiac arrest for patients who are pediatric patients. It's going to be hypoxic event, some sort of airway compromise that leads to hypoxia, which then further leads to arrest. Okay, so that's just something we need to keep in mind. Also with that, they have a decreased functional reserve volume, so they have less capacity to compensate if they have difficulty with ventilation oxygenation. So a goal for us too is, because they are so oxygen dependent, we really want to do our best to maintain good oxygenation and ventilation. And our goal should be to keep pediatric patients above 94% SpO2, if at all possible. And then one other thing, especially in our young, very young populations, or infants and toddlers, they're going to be diaphragm breathers, or commonly referred to as belly breathers. They don't have those developed intercostal muscles in order to be able to expand their chest as easily. And so they're going to be very reliant on that diaphragm. And so it's going to look like they're belly breathing. And so anything that interferes with that movement, with the movement of the diaphragm, can make it more difficult for them to ventilate appropriately. Okay, let's move up here to our cardiovascular system. We're not going to talk about in depth like the neonatal side of it, where we talk about like our foramen ovale and our ductus arteriosus, those changes. We're just going to consider this as we have a healthy patient who doesn't have any of those congenital heart defects, and what normal changes do we see in a pediatric patient. So a couple things is they're actually going to have increased blood volume per kilogram. So proportionally to their weight, they're going to have more blood per weight than a normal adult would. However, they have less absolute volume of blood, meaning that their total volume of blood is less than what an adult would have. That's intuitive. That makes sense. Kind of the number on that is going to be your 70 kilos per kilogram. So if you had a 20 kilo patient, then you're probably looking at about 70 times 20. That would be about 1,400 ml, so 1.4 liters of blood. So the significant takeaway from that is that a pediatric patient who's losing blood, it's going to be a smaller total amount of blood that is going to affect them than it would be for an adult. So even what looks like maybe minor or less severe bleeding comparatively to an adult, for a pediatric patient may actually be very severe because they have less absolute blood. Something with this as well is these patients have very good vasoconstriction ability, which allows them to compensate very well until they don't, right? So these patients can compensate because they're able to vasoconstrict to keep their pressures up, do their best to perfuse their vital organs. But then once they're no longer able to compensate, they can crash very quickly. Okay, so that should really cue us into being very aware of signs of shock, right? We should be looking for tachycardia. If we have tachycardia, we should be very suspicious that this patient is shocky, that they're hypovolemic and are compensating. Secondly, skin signs, capillary refill is going to be a very helpful thing for us to assess. If they have a capillary refill greater than 2 to 3 seconds, then we should be suspicious that there is decreased perfusion going on. Okay, so just remember that too. They can compensate very well, but once they don't compensate, they can crash very quickly. So always have a very high level of suspicion of a serious illness. Then finally, one other thing to note is our mediastinum in pediatric patients is a little bit more flexible or mobile. And what that can result is in when they do have some sort of trauma, there's less protection and can make them more susceptible to injuries to the organs in the mediastinum, so your lungs and your heart. So be aware of your signs and symptoms for like pulmonary contusion or cardiac tamponade and be ready to treat those appropriately as necessary. Okay, when we talk about our nervous system, just a couple things to talk about here. One is their neural tissue is more fragile than an adult, which can make it more prone to bleeding. So especially in our trauma settings, we should be very high suspicion of intracranial hemorrhage in these patients. We can have things such as shaken baby syndrome or even just basic head trauma, things like that. We should be very alert to, there's a high probability that these patients could have intracranial hemorrhage, and we should really do our best to oxygenate them appropriately, keep their perfusion appropriate, and do the best we can to keep their brain oxygenated, as there's higher chance of injury. And with that, so something to note is that for a pediatric patient in comparison to an adult patient, they actually need double the cerebral blood flow requirement. So they need double the cerebral blood flow in proportionally as compared to an adult in order to perfuse and oxygenate the brain appropriately. Okay, when we talk about the abdomen and pelvis, there's a few things that are going to be very applicable to us as pre-hospital care providers, especially in the trauma setting. Two of those things would be that they have a thinner abdominal wall, and they also have less protective muscles to help provide that support and the protection from trauma. And because of that, they're going to be more prone to trauma, as well as their solid organs, so especially their liver and spleen, are larger in proportion to the rest of their body as it would be in an adult. And they also sit a little bit lower and are not as protected by the rib cage. So normally for us, our liver is quite well protected, our spleen as well as quite well protected by our ribs. For the pediatric patients, it's going to be a little bit less protected by that. So if we have a patient who does have some sort of thoracic abdominal trauma, we should have a very high sense of suspicion of solid organ damage and then secondary significant blood loss. Okay, as we talk about musculoskeletal, this is kind of similar to what we've touched on already, but just remember that their bones are going to be a little more flexible. So we may see less fractures, but it doesn't mean that there's not internal damage, right? Because it can flex, we could still have damage to the organs which those bones are intended to protect. As well as less muscle mass, they have less protective muscle to help protect their internal organs again. Okay, then finally, when we talk about metabolic differences, one thing that we're going to see for pediatric patients is they have a limited glycogen store in comparison to adults. So when we are treating patients who are either having seizures or they're in shock and they're trying to compensate really hard or whatever the disease process may be, these patients are going to be much more prone to hypoglycemia because they can quickly burn through those glycogen stores in order to try and keep the energy supply to their body. And then when they run out of those stores, they can start to become hypoglycemic. So we should always be, no matter what our presentation is on the patient, if they seem to be sick, we should be checking that capillary blood glucose and then treating appropriately if they are hypoglycemic. Okay, then one other thing too is they have a higher risk of hypothermia. We know that pediatric patients have less ability to compensate and to regulate their body temperature. So that's just something that we should keep a very close eye on. We should be checking their temperature as well. We should be making sure we're keeping them in a warm environment, getting warm blankets, things like that. Okay, guys, I hope this is beneficial to you guys in understanding some of the anatomical differences. We're going to talk about a few more things about our pediatric patients, and then before we move into the cardiac arrest side of things. All right, guys, I wanted to briefly touch on our general assessment of our patients, especially in regards to our general impression as well as our vital signs. When we approach these patients, we need to perform a general impression, right? As we walk up to our patient, there's a few things we can observe that will help tell us about our pediatric patient, how they're doing. And then two, we have our vital signs, and we know that vitals are going to be specific for the age and size of our patients. So I wanted to just briefly go over that for you guys so that you have that in your head of kind of the baseline of, okay, what heart rate should we be looking for, what blood pressure should we be looking for in a pediatric patient. Especially, we're focusing in on cardiac arrest in this lecture, but it's important for us to know these, especially for the times when we do get ROSC on these patients. That way we know, okay, what are we targeting? What are we trying to get these patients into? Or if we have a patient who is peri-arrest, they're declining and very well could be going into arrest, well, this will help us know, okay, these are the targets that we're trying to get these patients back up to. Okay, so number one, the first thing we're going to do when we are assessing a pediatric patient is as we're walking up, kind of our 10-foot view is we're going to be doing our pediatric assessment triangle. Okay, so essentially we can still remember this as our ABCs, but it's going to be just slightly nuanced compared to our adults. Okay, so when we talk about our pediatric assessment triangle, we have three things we're looking at. We're looking at our general appearance, we're going to be looking at our breathing, or a lot of times you'll see this referred to specifically as your work of breathing, and circulation to skin. Okay, so we still have our ABCs, but instead of A being airway, A is general appearance, B is going to be our work of breathing, C is our circulation to skin. When we're considering our appearance, kind of the things we're looking for is just as we are walking up to our patient, how is this patient acting? Are they acting appropriate for the age? If it's a young infant or young toddler and they seem to be in distress, are they crying? Are they reaching out for their parents, those type of things, or are they just super lethargic, just not really responding very much, just super out of it, things like that we want to start to observe. So we're really kind of looking at what's their overall level of consciousness, how's their interactiveness, are they responding appropriately, or are they super agitated, whatever that may be. And then just kind of overall appearance, anything else that you may see as you're walking up, you're just kind of taking that all in. When you come to B, your work of breathing, this is where you're going to be looking for, is there anything that's telling me that this patient is having a difficult time breathing? Is there anything abnormal? Obviously, if there's no abnormal breathing as you walk up, that's a good thing. For the abnormal things that you should be looking for, there's a few things. So we got like nasal flaring. So if you see them flaring the nose significantly as they're trying to breathe, grunting, you may see retractions, those sternal retractions, or any other abnormal noises. That's going to clue you into that this patient is experiencing some sort of respiratory distress. When you guys see those retractions, it's something I've seen several times with these pediatric patients, and it's pretty obvious to note. Something I would always recommend, especially if the patient is wearing clothes, is to lift up that shirt, because that's going to give you a much better view to see if there are any sternal retractions, other retractions that would clue you into that this patient is working very hard in order to try and breathe. Also with breathing, this wouldn't necessarily be your 10-foot view, but as you're up with the patient, definitely take a listen to those lung sounds, see if those are normal or if there's wheezing or anything else. And then finally, your circulation to skin. This is going to be as you're walking up, you're going to be checking out the color. Is the patient really pale? Are they blue in color? Is their skin mottled? Is there any signs of bruising? Things like that. As well as you're going to be looking for cap refill. Again, this won't be your 10-foot view, but this will be as you actually start to touch the patient. You can check their cap refill. And if you have a prolonged cap refill greater than 2 or 3 seconds, then that's going to clue you into poor perfusion status. Okay, guys, so that's a brief overview of our pediatric assessment triangle. Let's go and take a look at our vital signs. So over here we have in our age, and we're going to talk about heart rate, respiratory rate, and blood pressure. So let's first start on our heart rate. So for our 0 to 3-month-old patients, we're going to see that our heart rate normal is anywhere from 80 to 205. Now, I think 80 would normally be on the lower side. Typically, especially like in your newborns, they're going to come out right around 150 is kind of your optimal. But these young patients, most likely they'll be stabilizing somewhere in that 130 to 150 range. But anywhere in that 82, 205 can be considered normal. Okay. For a 3 to 1 month old or a 1 to 2 year old, 75 to 190 is going to be the value we're looking at. And then from our 2 to 10 year olds, we're looking at 60 to 140. Okay. And then for our 10 to 18 year olds, we're going to go back to adult values there. 60 to 100 is what we consider normal. When it comes to our respiratory rate, we're going to see that our pediatrics, we talked about young patients, they have decreased tidal volume proportionally to adults. We're going to see, and they have doubled the oxygen consumption demand. So we're going to see that they're going to compensate for that with higher respiratory rate just naturally. So we see that from newborns to 1 year old, we're typically looking at about 30 to 60 breaths per minute is normal. For 1 to 4 year olds, about 24 to 40. 4 to 6 year olds are about 22 to 30. And then as we get to 6 to 13 year olds, 18 to 30, and then 13 and above, we're back to normal adult standards, which would be 12 to 20. As we look at our BP, there's going to be one rule that's super important to remember, which is going to be our 70 plus age times 2. You can really use that for about any ages over 1 year old. So let me step this way so you guys can see the entire chart. So for our 0 to 1 month old, so essentially our neonates, we're going to be looking at anything above 60 BP, 60 millimeters of mercury, systolic BP. So let me add that up here. This is going to be your minimum systolic. Okay, so minimum systolic BP. So if for 1 month or less, anything over 60 is considered appropriate. For our 1 month to 1 year old patient, anything over 70 is considered appropriate. And then after that, from 1 to 10 years old, we're going to be considering anything as you're going to take 70 plus their age in years times 2 would be their minimum systolic blood pressure. So to do a quick example of that, let's say we have a 3-year-old patient, right? So we're going to take 70. I'll do it up here so you guys can see it. So we have 70 plus age in years. We said 3 years old times 2. It's going to be our minimum systolic blood pressure. So now we get 70 plus 3 times 2, 6 equals 76 would be our minimum systolic blood pressure for a 3-year-old. So you can use that formula for anybody up to the age of 10. Then at 10 years and above, if you would use that formula, 10 times 2, that'd give you 20 plus 70, 90. So at 10, that's where it cuts off, and we're just back up to the normal adult values with 90 being our minimum systolic blood pressure. Okay, guys, I hope that's helpful. One more thing too I want to touch on is glucose. I didn't write that up here, but I'll write it over here. So our glucose levels for any patient who is less than 1 month. So less than 1 month. Glucose less than, sorry, I read this incorrectly. Anything greater than 40 milligrams per deciliter is considered normal. And then above 1 month, anything greater than 60 milligrams per deciliter. Okay, so let me just repeat that. So for patients who are less than 1 month, so your neonates, the treatable value, at least according to my protocols, again, refer to your own protocols, but according to mine, anything less than 40 milligrams per deciliter with some sort of signs of hypoglycemia, specifically altered mental status, then we would treat that patient. So less than 1 month, 40 milligrams per deciliter is your normal, like your low end, right? And then if you're low end of normal. For 1 month and up, then 60 milligrams per deciliter is your low end of normal. Below that, you begin to treat. Okay, guys, and then temperature is pretty standard. Across the board, you may see some different values, but just remember 36 to 38 degrees Celsius is pretty standard for all these patients. All right, I hope this helpful for your vitals. Definitely let me step out of the way here. Take a good look at these vitals. Try to get them in your mind. Remember the 70 plus age times 2 calculation. And these vitals will be very important for us as we come to either pre-arrest patients, patients who are declining, or post-arrest ROSC patients that we're working on stabilizing after that. All right, guys, we're now going to take a look at some of the most common causes of pediatric death. We're also going to look at some of the statistics that are related to those. I think this knowledge will be helpful for us when we are responding to pediatric cardiac arrest calls, giving us an idea of what are some of the most common causes of arrest, and that will allow us to mentally prepare for the treatments that will be necessary. So referring to NIH, the National Institute of Health, they listed these 4 causes as the most common causes of pediatric death. It was respiratory arrest, traumatic arrest, cardiac problems, or infectious problems. Then they also did talk briefly about SIDS, which is sudden infant death syndrome. I'll talk about that in a moment. When it comes to respiratory is our most common cause of death in pediatric patients, according to the NIH. And underneath respiratory, some common causes that we can see would be pneumonia, asthma, aspiration, smoke inhalation, asphyxiation, drowning. Now, as you'll note, there can be some overlap between like respiratory and infectious, and pneumonia, trauma, and respiratory and drowning or asphyxiation. So that's important to note. There is some overlap, but this is just saying that the primary cause of death, no matter what caused the respiratory issues, was a respiratory issue. So for patients too, asphyxiation, aspiration, drowning, these can be disease processes or injuries that we see commonly in certain age groups of patients. Asphyxiation can be very common, especially in our young patients. And aspiration can lead to asphyxiation. And so patients, whether it's just based on positioning, maybe they're choking on something, maybe they get into something, get a cord wrapped around their neck, whatever it may be, asphyxiation can be a common cause of death for these patients, as well as disease processes. Drowning, we know that's a common one with unprotected pools. Kid falls in, no one's around, things like that. Those can all be processes that do lead to death for our pediatric patients. And asthma as well. We talked about our pediatric patients have smaller airways, smaller diameter of airways. And due to that process, when we do have swelling, when we have blocking of those airways, it makes it much more difficult for the pediatric patient to move air. And therefore, asthma attacks can be lethal for these patients. When we talk about common causes of traumatic death for pediatrics, some common ones would be, you have 2 main categories. You'd have your accidental trauma and your non-accidental trauma, which would typically be classified in statistics as homicide. So it'd be like your abuse or specific intent to kill, abuse or homicide. But as we look at traumatic injuries, we actually see that motor vehicle accidents. It's interesting to look at the statistics because we see that from the 80s or late 70s to where we are now, MVAs has significantly decreased in the number of deaths caused by car accidents. Now, it's still a pretty big number comparatively to some of the other traumatic causes, but it is cool to see that number is coming down. So motor vehicle accidents, that's a common one we can see. Drowning, again, we said that kind of is overlap with respiratory, and then kind of the 2 main categories of accidental trauma. So really that's super broad, right? Any sort of accidental trauma. Could be a gunshot, a kid gets into a gun, accidentally pulls the trigger, it's fatal, whatever it could be. And then you have abuse, which this would be maybe not always with the intent to kill, but abusive actions that does end up leading to death. This could be shaken baby syndrome, wide variety of causes. And these, when we look at statistics will often be classified as homicide. When we look at the cardiac causes, there's going to be a few causes. We have some of the more congenital side of things, which would be your congenital lesions or defects that can lead to death. You have cardiomyopathy, so just disease of the cardiac muscle. And then you have things like commotio cordis and arrhythmias, just spontaneous arrhythmias that send the patient to cardiac arrest. Commotio cordis, recently, this wasn't a pediatric patient, but it was something that had very global, or maybe not global, but very national exposure. Is the Damar Hamlin event. Many of you guys have probably seen that, where he took a hit to the chest, right? And then just based on how he got hit, put him into cardiac arrest. We had early CPR started on him, great outcome for him. So this is one of those conditions that you'll often see in athletes and actually has pretty good survival rates considering cardiac arrest. I think the survival rate, this is just off the top of my head, so this isn't based in literature, but if I remember correctly, it's about in the range of 50%, which considering cardiac arrest is pretty good. Now, obviously that's still a very lethal and scary situation because half people will make it, half won't. But it's a condition that has pretty good response to defibrillation and hopefully good outcomes as long as high quality CPR has been provided. And arrhythmias, this is actually one that at the department I work for, we had an athlete just recently just go down into cardiac arrest due to arrhythmia, and thankfully we got him back. And so it's just one of those, that's another situation in which you can respond to, whether it's a sporting event or whatever it is, a child or a pediatric who has just spontaneously gone into cardiac arrest. And then finally, we have infectious. So infectious kind of common causes would be our meningitis or sepsis. So we want to make sure we're looking out for those signs and symptoms for those and initiating appropriate treatment for those patients if we have them before cardiac arrest, or that will be one of our considerations as we are treating a patient in cardiac arrest, is looking, does this patient have a history of an infection or anything like that that would lead us towards sepsis being the root cause. And then finally, I just wanted to mention SIDS, or sudden infant death syndrome. Don't necessarily have any specific statistics that I can tell you guys right off the top of my head right now on how often these occur, but they are fairly common in very young patients. And the definition of SIDS is a death of a young patient, so usually an infant. It would be an infant. And after investigation, looking over the patient's medical history, doing a detailed autopsy, as well as an investigation of the death scene, the area where the death occurred, nothing can be concluded. There's no obvious cause of death, then that patient would be considered a SIDS patient. So something we should be aware of is that sometimes, especially our very young patients, can, for some reason that's unknown, go into cardiac arrest and pass away. So that's something just to be aware of, is sometimes maybe the cause won't be very evident, and sometimes you'll be responding to these scenes when it's already too late. There's not anything you can do. And at that point, you're just gonna have to follow your death determination protocol, do your best to console the family, and handle the situation as professionally as you can. Okay, so as we start taking a look at some of our stats, we mentioned some of these causes. Let's take a look at what of our statistically most common causes of death in certain age groups. These statistics are based off stats from 2021. So a couple of years old, but still, I think, helpful. So as we look at this, we're gonna look at it in groups of our 1 to 4-year-olds and our 5 to 14-year-olds. And then this number here, our deaths per 100,000, that's how many children per 100,000 children die in the United States per year. Okay, so as we look at 1 to 4-year-olds, we see that in 2021, we had 25 per 100,000 children, pediatric patients of that age range, 1 to 4, who passed away. Okay, so as we think about that, it's a pretty low number, but it's also not insignificant. If you have, it makes you realize, especially depending on the population of your area that you serve, that pediatric cardiac arrest is a very real possibility and something you need to be very well prepared for. So our leading causes in our 1 to 4-year-olds, number 1 was unintentional injury. Number 2 was birth defects. We said that, some children are born with congenital heart defects, things like that can end up being lethal. So for these patients, that can start to present with complications at those ages and lead to death. Cancer is another common one. That was number 3. Actually, cancer and homicide, they were tied. So you could flip them, but they were actually equal. Homicides, this would be your abuse situations or your specific intent to kill situations. Heart disease was number 5. And then influenza or pneumonia was number 6. As we look at our 5 to 14-year-olds, so more of our children to adolescents, we see that our death per 100,000 went down a little bit. It was down to 14.3 in 2021 of 14.3 children per 100,000 children in that age range in the United States died in 2021. Leading cause, again, was unintentional injury. So we see that traumatic arrest is going to be our most common arrest call to respond to on pediatric children, and by pretty large margin. The unintentional injury in both of these categories was a much higher statistic than the ones below them. Next up would be cancer. Sadly, number 3 in this age range is suicide, and then number 4 is homicide. So we see again that these are most likely going to be maybe trauma, or could be drug overdose or things like that in our suicide. Homicide will most likely be trauma. So again, trauma is going to be a huge one for us, as well as there's some other things like toxins and any other asphyxiation, things like that. And then birth defects again was number 5, and then 6 was cardiac disease. So that just gives us some good information on what is going to be the most likely situation for us to respond to in a pediatric common arrest, with by far the most likely being unintentional injury. But we also want to keep an eye out for homicide, suicide, or any other possible causes. Now, when it comes to our survival rates in these categories, as I mentioned at the intro, the survival rates for pediatric cardiac arrest is not great. And that's the harsh reality, is that most of the time, statistically, most of the time, these patients won't make it. We do see that in hospital versus pre-hospital, much better chance in hospital. Large reason for that, I would believe, is that these cardiac arrests are going to be very quickly responded to, whereas pre-hospitally, it's going to take a little while for providers to arrive on scene. And so you're relying on bystander CPR, things like that, as well as less capabilities available. So our pre-hospital statistics for just general pediatric cardiac arrest, according to NIH again, was 8.4 survival rate, with unfortunately most of them having neurological deficits. So not very good neurological outcome for most of these patients. I didn't end up finding statistics on how many of them were neurologically intact, but reading the article, it sounded like very few were neurologically intact. So very low percentage that come away with neurologically intact. It's actually not bad though. When you look at 8.4, I mean, it's not good, but it was actually a little bit higher than I expected when I was looking up the statistics. 8 out of 100 children who go into cardiac arrest, 8 of them at least are alive at the end of it. It's better than I would have thought, but still a pretty low number. And we see that when we have patients who are non-traumatic in cause, so it's non-traumatic cardiac arrest, so that's ruling out all of our traumatic causes of death. It's even a lower percentage of survival. That'd be our 5.4% of pediatric cardiac arrest pre-hospitally that survive. As we look at in-hospital, like I said, in-hospital we have better outcomes, we have better neuro outcomes, and we have 24% chance of survival rate. And I think that's largely due to just very rapid response and rapid provision of care to these cardiac arrest patients. Okay, guys, I hope these statistics are helpful for you. I hope they open your eyes to a few things and help you to know what to better expect when it does come to treating pediatric cardiac arrest. All right, we're now going to take a look at the chain of survival when it comes to pediatric cardiac arrest. And with that, we're also going to talk about some scene management principles that we need to have ready in our minds for when we walk into a pediatric cardiac arrest scene. Because there's going to be a lot going on. It's going to be a very high stress environment. So we need to know, okay, this is how we're going to approach it in order to make the scene run as smoothly as possible, in order that the treatments and interventions can be performed and made the high priority. Okay, so as we talk about the chain of survival, you guys will know that the AHA has, for cardiac arrest, they kind of have their chart they'll put out there of the chain of survival of the certain things that need to happen in order to give patients the best chance of surviving. When it comes to pediatric cardiac arrest, the AHA has 5 steps in the pediatric chain of survival. Number 1 is going to be prevention. Okay, so prevention is going to be things like car seats or helmets, things like that. Anything that we can use in order to prevent injury and to help prevent cardiac arrest from occurring in the first place. The next chain of survival is going to be early CPR. So this is really going to be through the public, right? Through good education. Right? We need to educate parents and educate the public of the signs and symptoms of cardiac arrest, and then what to do, right? To provide high quality CPR while first responders are on the way to help. So we have early CPR, prevention, early CPR. Next one is going to be notification of emergency services. Okay, so this will be a notification, or you'll also see it referred to as call for help. Essentially, this is getting more help on the way, and end goal is to get us on scene, right? To get the paramedics on scene so we can perform our skills. So we need people to, number 1, we don't want cardiac arrest to occur, so we want to do the best we can to prevent it. When it does occur, high quality CPR is going to be extremely foundational in setting up this entire possibility of having a chain of survival. Because we know that in most best case scenarios, right, it's probably going to be at least 3 to 5 minutes before EMS can show up. And that's on a good scenario, meaning that where the cardiac arrest occurs is close to the station that EMS is staged at. So early CPR by bystanders, by parents or by bystanders is going to be so important in order to be able to give this pediatric patient a good chance of survival. The next up is notification for help, call for help. And they do say for the call for help, if it's a witnessed cardiac arrest, so if a parent or if you as a EMS provider, whatever it may be, you see the pediatric patient go down, it's a witnessed arrest, they actually recommend that before you start CPR, you go call for help. If you don't have a mobile phone on you immediately, according to AHA, it's worth the extra time to go quickly run, call for help, and then come back and just begin CPR. However, they say if it's a unwitnessed arrest, to actually go ahead and do 2 minutes of CPR. So that'd be about 5 cycles of CPR. And then from there, take a brief pause, go call 911, get more help on the way, and then come back and continue CPR. Now, optimally, right, if we have a cell phone on us, if we have a radio on us, we can hopefully do all this without interrupting CPR. Because we know that, if we look at a CPR chart, right, as we're talking about perfusion to the body and to the brain especially, we see that as CPR progresses, it slowly makes its way up. And then when we stop CPR, it really drops back down. Our perfusion's not so good. And as we do CPR, it continues back up. And then pause, comes back down, kind of works its way back up, pause, back down. So we see that any of these pauses are going to significantly decrease our perfusion to the brain and to our vital organs. And so as many of these pauses as we can reduce, it's going to give a better chance of survival for these patients. So with all that being said, try to call for help as fast as you can. And if you can do it without pausing CPR, then that's optimal. But if you do have a witnessed arrest, the recommendation is to call for help immediately, even if that means having to leave the patient briefly. If you have an unwitnessed arrest, the recommendation is to do 2 minutes or 5 cycles of CPR, take a brief pause, call for help, and then resume. Okay, so we have prevention, early CPR, notification, and then it's going to be timely ALS care. Okay, so this is going to be a big part of our role, right? This is going to be the main part of our role as paramedics, is showing up and providing ALS care. So that's going to be, and we're going to talk about it, right? Our algorithm for pediatric cardiac arrest and our treatments, whether that's, it's definitely going to be including CPR, airway management, hopefully defibrillation if we have shockable rhythms, and then pharmacologic interventions. Okay, so we have timely ALS care, and then after we get ROSC, if we do get ROSC, then the next one is going to be aggressive ROSC management. Okay, and so that's going to be, we achieve ROSC, we have a pulse back. Now it's going to be managing all of our ABCs, our oxygenation, perfusion, ventilation, all those things, and managing our patient, setting them up in the most optimal position to increase the perfusion to the brain and hopefully help them to have a good overall outcome. Okay, so yeah, just remember chain of survival: prevention, early CPR, notification, timely ALS care, and then aggressive post-resuscitation management. Okay, now let's go ahead and think about now as we arrive on scene. We know that a pediatric cardiac arrest is most likely going to be a very high stress situation right off the bat. You most likely have parents that are very emotionally, very highly stressed. And for EMS providers, as I mentioned at the start of the video, it's not a call we go on super commonly. And it just feels to us when we show up on these calls that's higher stakes, right? Because we're dealing with a child. And so because of that, it can increase the stress management. And if we're not very intentional about how we manage the scene, it can very easily become a very high stress scene and one that runs chaotically instead of running very smoothly. So there's a few principles that we need to understand when it comes to scene management of pediatric cardiac arrest. So we have scene management itself, which is going to be more of our crew resource management. We have our family management, because we know that the family members are most likely to be very highly stressed. So we need to be able to manage them in a way that is going to allow us to do our job, as well as to allow them to know what's going on and to provide some support and comfort for them in the midst of this very highly stressful situation. And then finally, it's going to be emotional management of how do we keep our emotions calm in the moment, as well as how do we manage it long term. Okay, so as we talk about scene management, number one is going to be our scene safety, right? And that's something that is standard no matter what call we're going on. When we're walking into the scene, we need to not be getting tunnel vision on, oh, I have a patient right here I need to treat, but we should be getting a good view of what we're walking into. Was there violence that was involved in this call? Why is this pediatric patient in cardiac arrest, other toxins, things like that? So the last thing we want to do is walk in and then ourselves become another patient and another victim. Okay, so we always need to be making sure scene safety is high on the priority, even in these situations in which we're going to be very prone to get laser focused on the patient, but we need to be able to just take that brief second, look around, make sure the scene's safe, then go to work. Okay, number two is going to be designating our roles. So this is one of those things that I feel like is so important on cardiac arrest, is if everybody knows specifically what role their purpose is on scene, then things can go very smoothly. However, on the other side of things, if people don't know the roles and everybody's kind of freelancing, just trying to figure out what to do, then that makes the scene a lot more prone to being chaotic and for things not getting done in the appropriate time frames and appropriate interventions being performed at the correct times. Okay, so that's going to be something that's very important, especially if you're the team lead on the call, is to be very clear in how you communicate, right? Saying, if you have a partner, tell that person specifically, hey, I want you on CPR. I want you airway management. You're going to be my access medication management. You're going to be replacing the CPR person in 2 minutes. You guys will switch. Communication like that in order to make sure that your communication is very clear. Everybody knows exactly what they're doing. That way you don't have overlap of things and wasted time, but rather you have each person working on what they're supposed to be doing, and you get those high priority interventions accomplished effectively. Okay, and with that is our clear closed loop communication, right? So it's very important for us in these situations. Time is of the essence, and clear communication is so important. So we need to have, when we talk closed loop communication, it's when we say, hey, I need you to do this, the other person needs to confirm that they heard it and say it back to you, right? So if you say, hey, I need you to administer, you have 20 kilo patient, I need you to administer 0.2 milligrams of epinephrine, to this patient, that the person who's administering the medication should say, okay, I will administer 0.2 milligrams epinephrine. Something like that, where you have just good, clear, concise communication that's repeated back so that your partners are communicating, okay, we heard what you said. This is what you said. Make sure there's not an inaccuracy in the communication, and then it's getting done. Okay, so make sure you're communicating very clearly and being a very good, strong presence as team lead on these calls. And then finally, like I said, prevent tunnel vision. Make sure you are looking around the scene and assessing your patient, right? You want to make sure you're not missing any critical factors of whether something you could see on the scene that leads you to the cause of the arrest, maybe something on the patient themselves that leads you to the cause of the arrest, or any information that's going to help you in your treatments of these patients. So make sure you don't just get tunnel vision, but you kind of keep your head on a swivel or looking around, assessing the scene, assessing the patient. That way you can get the information that you need in order to best treat your patient. Okay, as we talk about family management, this is going to be one of the more difficult ones. And for me, I run in a fire EMS system. So we're full-time firefighters, full-time paramedics. And because of that, we run with a battalion chief, which makes it very nice for us in this aspect of it. Because for me, when I show up on scene of a cardiac arrest, my job is to get on scene to run the arrest, right? I'll have my AMTs helping me, maybe just a couple other medics there helping, and then I'll have my battalion chief showing up as well. And he really takes this role of the kind of the family liaison role, where he's able to talk to the family, kind of tell them what's going on, communicate everything that we're doing. And that takes a load off the people who are trying to run the arrest. And so I think that's very valuable, whether you guys run in a format like that or run in some other form of EMS response, being able to have somebody on scene. And obviously this is gonna be something that, if you need the hands for the treatment of the patient, that's gonna take top priority. But if you are able to set someone aside, or at least specifically designate someone to say, hey, when you have a chance, when we have a moment where it's not gonna make our patient care suffer, to communicate with the family, it's gonna make things go much more smoothly. Because it's going to allow us to, provide resources to provide information to the family, offer them resources, especially if this has a negative outcome of, counseling resources, whatever it may be that your city provides, get them in touch with those, as well as it helps us to show that we respect them and we're respecting their emotions and their feelings through it. And we want to make sure that we respect their privacy and the privacy of the patient during the process. So if you have somebody on your crew, you have an extra hand that, without making patient care itself suffer, that can go talk specifically to the family, tell them, okay, this is what we're doing, why we're doing it, this is what we're seeing, all those things, that will very much help in your communication with the family. And also this family liaison, a role that they may have to serve, is kind of separating the family from the scene slightly. Because we know that if you have family members who are very, I guess, high stressed, I should say, and are really, making a distraction on the scene, it can make it more difficult to do patient care. So this family liaison person's role is going to be able to explain what's going on to the family members and hopefully just get them far enough away from the scene that it's not interfering with patient care. Okay, and then finally we have emotional management. This is going to be for us specifically as pre-hospital care providers. We know that these scenes can very easily become emotional for us. Number one, or I guess two points I want to say that when we're on scene that we should remember is: number one, do your best to remain calm. Number two, know your role. What I mean by that is remaining calm, even though you may be stressed on the inside, especially if you're the team lead, do your best during that call, during that 20, 30 minutes that you're treating this patient. It could be more, but during that time that you're treating this patient, do your best to present an outward calm, right? That doesn't mean you can't ask questions. If you have something where you're like, oh man, I'm not sure, should I do this? Definitely use your crew members to help you with that. But present a calm demeanor as you run the call, because the demeanor that you present is going to very much influence the demeanor of those who are helping you, your other crew members, and it will influence the entire way the and will influence the entire way that you guys as a team perform. That's what I'm trying to say. So if you can remain calm, present that calm front, that's going to help everyone around you. And when I say know your role, this will help you in the moment for sure, is knowing that, my role is to come and help, right? These situations are going to happen regardless of whether I'm showing up or not. And so I can't, under my own power, make these things not happen. What I can do is show up, do my job to the best of my ability. If a good result is there, that's awesome. Super cool opportunity to be involved in saving a life. If it's not a good outcome, then I can walk away saying, I did my job and I did it well. So when I say know your role, I just mean this is not necessarily your own emergency, right? You're trained for this. and it's your time to show up, stay calm, do your job. Later, there will inevitably be some emotions, but allow during that time you're working on the call, push those emotions aside, do your job, do it well, and that's going to make everything better. Your patient care will be better, and your being able to manage with the emotions of it after the call will be better because you know you showed up and did your job to the best of your ability. A couple things for the after the call that we need to, which are very beneficial for us to have in place in our system, is one, I think, team debrief, right? If you have, after one of these calls, have a moment where you guys can meet back at the station or whatever is best location for you guys, and just talk about it. Say, okay, what did we do well? What can we do better? And then also just talk about the emotional side of it. How are you guys doing? This was a tough call. Is everybody doing okay? You know, have that moment to kind of let people express their feelings about the call, and, you know, hopefully have some good constructive conversation about it. And then finally, crisis support. It's important for us to have avenues that if, you know, these calls are really just tearing us up on the inside emotionally, to have avenues to where we can go talk to somebody and we can get some professional help on that. Okay, guys, I hope this is helpful. We're now going to dive into, after we come and do our initial scene management and talk about some principles going into it, we're now going to talk about, okay, how do we actually run the cardiac arrest? What is our correct procedures, correct algorithm to perform? All right, guys, as we talk about our pediatric cardiac arrest and how we're going to run these calls, it's important for us to start with the basics and make sure we understand the basics of CPR when it comes to pediatric patients, as well as the basics of airway management. Okay, so as we come to CPR, there's a few considerations we need to have. One is going to be the size of our patient. We know that if we have very small patients or infants, there's a couple techniques that you can do to perform CPR, right? There's the 2-thumb method, where if you're able to fit your hand around the patient, get your 2 thumbs on the sternum where you're doing compressions, you can compress that way. But also the 2-finger method, where you can take 2 fingers, right, same place, and perform your compressions that way. Once you're treating pediatric patients who are a little bit larger, you can go to more of a conventional CPR method, which would be either the 2 hands or you could do 1 hand CPR method, whatever's gonna be best. But as long as you're getting your hands on the correct position on the sternum and getting the correct depth and ratio, then you're gonna be performing good, effective CPR. And so really you're just gonna have to determine based on the size of my patient, am I going to be able to do it best? Thumb method, 2-finger method, or more of a conventional CPR method, okay? And typically the thumb and 2-finger, like I said, is gonna be for very small infant patients. Okay, when it comes to the basics of our CPR, there's a few main knowledge points that we need to understand when it comes to performing high quality CPR for pediatric patients. So one, when we talk about our quality of compressions and quality of CPR, we need to remember that our compression depth for these patients needs to be about 1/3 of the chest wall, right? So 1/3 of the anterior posterior chest diameter. So when we're performing compressions, right, we want to make sure that if we take back to chest, that our compressions are going about 1/3 of the way depth, right? That's going to be making sure we're getting good enough depth that hopefully we're going to be given that movement of blood flow through the heart. For our ratio, this is going to be the same as it is for adults. We're going to be performing a compression ratio of aiming for 100 to 120 compressions per minute, okay? So that's gonna be no different than doing CPR on an adult patient. You're just gonna be maintaining that same ratio, okay? Really aiming for that 110 is what I like to do because that gets you right in the middle, even if you're off just a little bit. And then again, not any different from adult cardiac arrest, but it's super important for us to remember to give full chest recoil, right? That's gonna aid in refilling the heart with blood. So if we are on the chest, right, we perform compressions, we wanna make sure we're always coming off just slightly. That way we know we have full recoil and are hopefully allowing the refilling of blood into the heart. And then again, with CPR, we want to switch our compressors every 2 minutes as needed. So this isn't a, mandated, you have to do this every 2 minutes, but if you have a compressor who is beginning to fatigue and you are wary that their quality of compressions is going to suffer due to that, then switching your compressors can be very helpful into maintaining good high quality CPR. So it's a good habit, even though, I think a lot of us would like to say, hey, I can do CPR for longer than 2 minutes. It's a good habit just to switch, whether you feel tired or not. That way you don't get to that point where you're fatigued and quality decreases. So those are just some good points for us to remember, right? 1/3 of the chest depth, 100 to 120 compressions per minute. Make sure you allow good recoil, and then switch compressors every 2 minutes if possible. Okay, when it comes to our ratio of CPR for pediatric patients, this is going to depend on a couple things, right? And one thing I should mention here is AHA, when we're going down the pediatric cardiac arrest algorithm, they typically consider pediatric patients anywhere from the age of newborn patient to the age of puberty, the onset of puberty. So if you have a patient who has the physical signs of puberty onset, they'll typically go up to the adult cardiac arrest algorithm. So that's just something for us to note, especially as we talk about ratios here. So if you have a patient who has not hit puberty yet, still in the pediatric patient, when it comes to our ratio, there's going to be our ratio of compressions to ventilations. It's going to be determined on the situation in which we're in. Okay, so if we arrive on scene with just one provider, right? So maybe you're a single resource medic on a squad, maybe you're off-duty medic, whatever it may be, and you arrive on scene and there's only one person providing CPR, then in that case, we're going to do a 30-2 ratio. Okay, so what that means, right, is we're going to do 30 compressions, pause, 2 breaths, or maybe we're using a pocket mask and providing ventilations that way. Okay, so 30-2, pause, 2 breaths, resume that. If we have 2 or more providers and we have our pediatric patients, then our ratio is now going to be 15-2. Okay, because we know that ventilations for pediatric patients is very important in these cardiac arrest scenarios. So the main reason between the difference, right, is that one provider, it's going to be difficult for you to provide high quality CPR, 2 breaths, high quality CPR. If you're doing it at a 15-2 ratio, it's a lot of switching to do. Whereas if you have more providers, right, one person be on the airway, one person can be on compressions, you give those 15, brief pause, breath, and then keep going. So that's just something for us to remember, right? If one provider, we're sticking to the classic 30-2 ratio. But if we have 2 providers or more, pediatric patient, we're going 15-2. Once we have an advanced airway placed, our compressions are actually now going to become continuous. Okay, so we'll have good continuous compressions, again at 100 to 120 compressions per minute. And now that we have an advanced airway, our ventilations can be just asynchronous with our compressions, and we're aiming to give a breath every 2 to 3 seconds. Okay, so this will come out to approximately 20 breaths per minute. Okay, so yeah, let's just recap that. So we have pediatric patient, anywhere from an infant to the onset of puberty. If we have one provider, we're going 30-2, like we would for any other cardiac arrest. 2 providers, we're going 15-2 on our compression to ventilation ratio. And then once we have an advanced airway place, we can switch to continuous compressions with ventilations provided every 2 to 3 seconds. Okay, when it comes to our airway considerations for pediatric arrest, typically, right, when we arrive on scene, we're going to begin compressions and then begin providing bag valve mask ventilations. So when we do BVM, right, we know that our typical grip, right, is going to be a C in 3. We're really giving a good jaw thrust, doing our best to get a really good seal, and then providing ventilations appropriately, just enough to cause the chest to rise. When it comes to really any patients, but even especially pediatric patients, we really want to prefer a 2-person BVM if possible, if we have enough hands to perform that, right? So in that case, you can have one person really just holding the seal, holding the airway position, and the other person providing the ventilations on the BVM. That's going to help us get much better seal and hopefully much more effective ventilations. There's also a helpful mnemonic for us to remember. Now this mnemonic, Mr. SOPA, was mainly developed in the neonatal resuscitation program world, but I think it actually has some helpful applications to patients who are older than neonates as well. Okay, so this is a good mnemonic if we're having a difficult time getting good ventilations with a BVM, of some things that we can check and adjust in order to hopefully improve those ventilations. So number 1 would be our mask seal. So we'd consider, okay, why am I not getting good ventilations? Maybe my seal is poor. And so maybe you adjust your grip, adjust your airway positioning. Maybe you now do the 2-person seal with a ventilation, whatever it may be, to get a better seal. That's something you're going to consider. Number 2 for your R is going to be reposition your airway. So maybe getting a better jaw thrust, better positioning of the entire body, and maybe padding under the head to get a good sniffing position, whatever it may be. Getting a good head tilt chin lift, whatever you can do to optimize the position of the airway, that will help you with your ventilations. And it really is incredible how much this can help. Doing this on patients in the OR or in the field, I've seen big differences in just, maybe the patient's head is more in this position, you get it in a better sniffing position. You'll really see that it opens up the airway. You're able to get much better ventilations. Suction, so you're going to suction the mouth and then the nose. Again, this is just to clear any secretions or any plugs that may be keeping you from having effective ventilations on this patient. And this can be done with a bulb syringe, or maybe you have French catheter suctions, or if it's a larger patient, you can use a Yankauer or Decanto suction catheter to perform this. And then next step is going to be to open the mouth and lift the jaw. So this is kind of similar to reposition the airway, but it's just making sure that mouth is open, so there's passageway for the air to go through. Lifting the jaw will just help to position that airway, hopefully keep the tongue out of the way. And then if needed, you can increase the pressure of your ventilations gradually. Now, obviously, we know we don't want to be given massive pressure ventilations because we can cause barotrauma performing that. With the Mr. SOPA pneumonic, they do say about 40 centimeters of water PIP is the most you want to go to. Some of your BVMs may tell you what PIP you're providing at. But if you find you're having a hard time getting good ventilations, you can increase that pressure as needed. Okay. Also, just to consider too, when you're providing CPR in patients, a lot of times your PIPs are going to be really high because you're going to have that pressure from your compressions. Now, if you're doing the 15-2, you will be giving those ventilations when you're not having compressions going on. So you may be able to monitor and get more accurate pressures that way. Once you do have continuous compressions going on, you may see your pressures very high. That might just be something you have to live with due to performing CPR. Okay, so you can increase your pressure gradually, and then the next and last consideration here on Mr. SOPA is going to be your airway adjunct. So whether that's an OPA, NPA, or our advanced airways like a supraglottic or an endotracheal tube. And that takes us to our discussion of what's best in pediatric arrest patients. Is the supraglottic airway better, or is the endotracheal tube better? Now, we know that the advanced airways, it is going to be beneficial for us to place one because it's going to allow us to switch to continuous compressions, right? And we talked about how anytime we pause on compressions, reduces our blood flow, and then we have to recruit it back and keep it going. So that's the great thing about placing advanced airway is that we can now do continuous compressions with asynchronous ventilations. And at this point, we have to decide, okay, what's going to be better then, the supraglottic airway or the endotracheal tube intubation? Okay, I'm doing research on it. So my own protocols, they prefer the supraglottic, especially in pediatric patients, over the endotracheal tube during cardiac arrest. And I was looking up the studies, and what the studies actually do show is they show that there's increased positive outcomes, 30-day survival rates and neuro outcomes with the use of supraglottic airways. There's a pretty good trial size, lots of patients, and they found that while there was no statistically significant difference between ROSC in patients that their airways were managed with an endotracheal tube versus a supraglottic airway, they did find that long-term outcomes was quite significantly increased in patients who had supraglottic versus the endotracheal tube. One of the main considerations for that is a lot of times with endotracheal tube intubation, if it takes too long, you can cause more of a hypoxic event, can decrease perfusion to the brain, or oxygenation, which will then decrease the oxygenation to the brain and to the rest of the body. And so that's why supraglottics can be a really good option, is especially if different supraglottics are out there, right? LMAs, King Airways, iGels, which my agency uses. And the iGels are awesome, right? You just grab it, throw it right down, easier than throwing an OPA, in my opinion, then you have a really good airway. So the benefit of those is that you can place them very quickly, decrease the likelihood of having a hypoxic event while you're trying to secure the airway, and then give you really good ventilations. Now, they're obviously not going to protect the airway from secretions and vomitus as much as an endotracheal tube would, but they will give you a good adjunct for providing good ventilations. And studies have showed increased patient outcomes, positive patient outcomes using supraglottic. So my personal take on it, my protocols would agree with it as well, is that when in doubt, go for the supraglottic airway. There may be times in which the clinical situation indicates I need an endotracheal tube. Maybe there's significant secretions, vomit, blood, things like that in the airway that you really need to secure that airway to keep from aspiration occurring. But unless there's something that really is indicating you towards placing an endotracheal tube, I would, on a normal, just pediatric cardiac arrest, I would err on the side of a supraglottic. If we do choose to perform endotracheal intubation on these patients, there's a few considerations we need to have with our pediatric patients. Now, we're not going to go into depth of pediatric airway management. That'll be another lecture for you guys on CE. But there's just some basics for us to know on the cardiac arrest. And that's going to be one that are, like we said in our anatomy, our patients have smaller airways, more anterior airways, and a floppy epiglottis that can obscure our view when we're trying to visualize the cords and pass the tube. So because of that, and we'll talk about this in our video talking about medications and equipment sizing, but a lot of times we're going to be using a Miller blade, right, to pull the epiglottis out of the way that we can get a good direct view to the cords. And then just remember to avoid prolonged attempts because we don't want to cause hypoxia. So if you go in there, not able to get a good view, it can be tempting when you're in the airway, right, to be like, oh man, I'm almost there, and just keep going. But make sure you have someone who's there keeping you accountable, timing you, watching your monitor and saying, okay, man, it's been 15, 20, 30 seconds, it's time to pull out BVM, throw the supraglottic. Or if you don't carry supraglottics, BVM them, get them well oxygenated again, and then you can go for a second attempt if necessary. Okay, so those are a few considerations with airway. Biggest takeaway, right, is Mr. SOPA, be ready to get a really good seal, reposition your airway, troubleshoot why you're not getting a good seal or good ventilations on a BVM. And then 2, if you're choosing between an endotracheal tube or supraglottic, my personal take and my protocol's take would be to place the supraglottic because the studies show better outcomes with that. Okay, let's talk about our cardiac arrest algorithm. Okay, let's go ahead and talk about the pediatric cardiac arrest algorithm. So this is the algorithm that we're going to use when we come upon the scenario of a pediatric cardiac arrest. We show up, we have a pediatric patient is pulseless, apneic, unresponsive. We decide, okay, it's time to begin CPR. Where do we go from there? This algorithm is very much going to help guide our care and make sure that we follow the appropriate order of operations in our interventions, provide the best care possible in order to hopefully have a successful outcome. Okay, so let's go through our algorithm. So as we come upon a patient who is a pediatric patient and is in cardiac arrest, initially we're going to begin CPR. Okay, we talked about for pediatric CPR, if we have a patient from the age of infant or newborn to a patient who begins to present with the signs of puberty, then that patient we're going to use 15:2 compression to ventilation ratio. Now that's if we have 2 or more rescuers. If it's still just single rescuer, just yourself performing CPR, then you're going to remain at the 30:2. But if you have a patient who you have 2 rescuers and is younger than the age of puberty, then that patient you're going to perform 15:2 CPR. Okay, so we're going to begin CPR. Most likely this will be 15:2 if it's a young patient, and most of us are going to be arriving with at least 2 people. If you are a single resource, showing up, like I said, 32. So we're going to begin with CPR, and then our first step too after beginning CPR is we're going to place our pads. Okay, so you want our defibrillator pads placed. Okay, at that point, we're going to monitor our rhythm. Okay, and we're going to say, okay, is it shockable or not? Okay, and just as a reminder, so our shockable rhythms, that's going to be our VFib and our VTAC. Okay, our pulseless VTAC. And then our non-shockable, that's going to be our PEA, pulseless electrical activity, and our asystole. Okay, so this is going to decide which side of the algorithm we go to. If we monitor our rhythm and the first presenting rhythm we have is shockable, whether it's VFib or VTAC, we're going to go over here on the left side. If we have a non-shockable rhythm, so either PEA or asystole, then we're going to go over to the non-shockable side. Okay. All right, so let's go ahead and start on our left side over here, our shockable rhythms. So again, we said we saw VFib, VTAC. So we monitor VFib or VTAC on the monitor with no pulse. And again, just make sure when you're monitoring these pulses, you're not performing CPR at the same time, right? You pause for a second, monitor your rhythm to make sure that you're not going to artifact from compressions that you yourself are given. So you monitor VFib, VTAC. And at that point, if you have that pulseless patient, right, you're going to deliver a shock. Okay. Shock, and we said that typically we're starting at 2 joules per kilogram up to 10 per kilogram. Okay. So how I remember that is 2, 4, 6, 8. That's how we defibrillate for pediatric patients. That's a good mnemonic to help you remember that you can escalate the doses as you go. And how AHA has it on their algorithm, and I'll put a picture of this up on the screen for you guys after we're done with this video, so you can review AHA's algorithm. And this is very much based off of it. This should be the exact same, but I'll just show you their format. You'll see that it says start with 2 joules per kilogram, next one go to 4 joules per kilogram, and then doses after that, you can do anywhere from 4 up to 10. Okay, so you don't necessarily have to continue escalating the doses, but you definitely can. Okay, so we're gonna shock that patient. And then after that, we're going to resume CPR, right? Remember that we're gonna defibrillate, deliver a shock, and then we're gonna immediately resume CPR, right? We're gonna do that for 2 minutes before we do another pulse check. So we're gonna begin CPR again, and then we're gonna work on getting IV IO access, okay? So that's gonna be our top priority there. Again, we're also providing good ventilations, right? We should have good bag valve mask ventilations going on at this point. So, and that's something that is included over here, right, is BVM ventilations. We should be, like we said, 15:2, so hopefully we're giving good ventilations. So we come over here, CPR, so we've seen VFib, VTAC, we've delivered our first shock at 2 joules per kilogram. Resume CPR, we try to obtain IV or IO access within that 2 minutes. After 2 minutes, we're again gonna do another pulse rhythm monitor check. And now we're again gonna ask the same question. Is it shockable or not? If the answer is yes, then we're going to continue down this algorithm. If the answer is no, then we're actually gonna come back over here to our non-shockable, excuse me, our non-shockable side of the algorithm. But we're gonna continue down this. So we're gonna say, yes, we still do have VFib or VTAC. So at this point, we're going to deliver another shock. So the answer was yes. And we're now delivering another shock. This time we're going to go 4 joules per kilogram. Okay. After we've delivered the shock, we're again going to resume CPR. And then we're going to administer our first dose of epi during this 2 minutes, assuming we were able to get IV or IO access. And we also want to consider an advanced airway. Okay, we discussed advanced airways in our advanced airway part of the video. And we said that for pediatric patients, the literature shows better outcomes for these patients with supraglottic airways versus endotracheal tube intubation. Now, it'll be a decision you have to make based on your clinical judgment. But just remember, if you can get a supraglottic airway in there, give ventilations with that, the literature seems to support better outcomes for those patients. So just to recap, right? VFib, VTAC, we shocked once. We performed 2 minutes of CPR. We obtained an IV and an IO during that time. We again monitored our rhythm after 2 minutes. No pulse. We had VFib or VTAC, a shockable rhythm. We deliver a shock, 4 joules per kilogram. We now resume CPR for another 2 minutes, trying to limit our time off the chest as much as possible, have as limited amount of breaks in CPR as we can. We're going to administer our epinephrine. We said the epi, we're given 0.01 mg per kg. Okay, and then we're considering advanced airway. Now, it's not mandated, right, that you get an advanced airway, but if you can, it will be beneficial to your patient, especially if you can do it quickly without causing a hypoxic period. Okay, so we're going to perform another two minutes of CPR there. And then we're going to determine, after our 2 minutes, we're going to do another pulse check. No pulse, and if we have another shockable rhythm, VFib or VTAC, we're going to continue down the algorithm. So we're again going to perform another defibrillation, give another shock. This time we'd likely be at 6 joules per kilogram. And then we're going to resume CPR for another 2 minutes. Okay, so we're going to do CPR again. Hopefully we have an advanced airway at this point. And we're also now going to administer our amiodarone. Okay, AMI, and this is going to be at 5 mg per kg. Okay, and then after we perform 2 minutes of CPR, right, we're going to come back up. We're going to determine, okay, am I in a shockable rhythm? If the answer is yes, then we're going to continue back down this, doing everything again, right? We can do another round of epi. We can do epi every 3 to 5 minutes. And then if we deliver another shock, come down here to amiodarone, we can do another 5 milligrams per kilogram. We can do this up until we administer 15 milligrams per kilogram of amiodarone. And my protocol is to consider stopping epi after 3, but it's not a hard and fast rule. You can really do as many rounds of epi as you deem is appropriate. And again, refer to your own protocols on that. Okay, so let's recap our shockable rhythm real quick side of it. And just remember that if you ever on these pulse checks get a no, then we're jumping over to our non-shockable rhythm. Let's recap our shockable rhythm algorithm. So again, we come up, pulseless patient, we begin CPR, we place our pads, we begin BVM ventilations. We determine that the patient is in VFib or VTAC, which is a shockable rhythm. Okay, so that brings us up here. We're going to deliver a shock, 2 joules per kilogram. We're immediately going to resume CPR. We're going to do that for 2 minutes. We're going to make a high priority get IV or IO access. After 2 minutes, we're going to do another pulse rhythm monitor check. If we remain pulseless but remain in a shockable rhythm, we'll deliver another shock, most likely this time at 4 joules per kilogram. Resume CPR for 2 minutes. During this phase, we're going to give 1 dose of epi, about at 0.01 milligrams per kilogram, and we should consider an advanced airway. Okay. Another pulse check. If it's shockable, we're going to shock. This time, most likely, we'll be at 6 joules per kilogram if we're continuing to escalate by 2 joules per kilogram dosages. Then we're going to resume CPR. We're now going to perform CPR for 2 minutes, and we're going to give amiodarone at 5 milligrams per kilogram. One more thing I should note on here is we're now going to consider our H's and T's, which we talked about in the last video. Okay, so you're going to consider your H's and T's. And then if you come back up here, remains unshockable, you're going to come back down this route, right?
I can only do that when you're listening to a song.
Sorry, guys, we got Siri wanting to talk to us. But so, like I said, so we've given our amiodarone, we're considering our H's and T's. We come up here, it's shockable, still is. Then we can come down, give another dose of epi, continue CPR, shockable again, deliver another shock. And again, we can escalate up to a max of 10 joules per kilogram. And give another dose of AMI. If we remain shockable, we can do another round of epi, another round of amiodarone. After 3 doses of amiodarone in pediatrics, if we're doing 5 mg per kg, and that's going to get us to our max dose on that. After that, we would just continue in our rounds of epi if indicated by our protocols. And then if we're in prolonged or a refractory VFib, there are some other medications which we'll talk about in our medication video after this one, talk about medications we can consider for refractory VFib. And then also we'll be making a transport decision. Okay. If at any point during this time we get ROSC, then we're going to be switching to ROSC protocol. Okay. So that's our shockable rhythm. Let's go over to our non-shockable. So we come to our patient, right? Pulseless, apneic, unresponsive, determine our patient is in cardiac arrest. We begin CPR, and we're going to begin ventilating with BVM. Place our defibrillator pads on. We hands off the patient for a second to see, okay, do we have a shockable rhythm or non-shockable rhythm? This time we have PEA or we have asystole. So we're going to begin going down the non-shockable rhythm side of things. Okay, so again, right, we have asystole or PEA. Okay, our top priority here is going to be providing high quality CPR and then getting epinephrine on it as fast as we can. Okay, so epi ASAP. And again, right, this is 0.01 milligrams per kilogram. Okay, we're gonna we have a non-shockable rhythm. We're gonna make that our goal of getting epinephrine on board as quickly as we can. So we're gonna come here, we're gonna perform CPR, we're gonna get IV IO access. And as soon as we have that, we're going to administer our epi. And again, we can do this every 3 to 5 minutes. Okay, and then we're going to, after 2 minutes of that, we're going to come down, ask is it shockable. If we're still in PEA or asystole, then we're going to continue down the algorithm. If we do now have VFib or VTAC shockable rhythm, we're going to come over here to step number 6. Go to 6. Okay, we're going to come over here and start down this route, the epi-AMI route. If we already in epi, then we can move down to the AMI route. Okay, but if we remain at no for shockable, then we're now going to continue CPR. Consider advanced airway. And we're going to consider our H's and T's. Okay, and then just remember epinephrine every 3 to 5 minutes. Okay, then if we come down, again, after 2 minutes, we do another pulse rhythm monitor check. And we ask, okay, is it shockable? And we again get the answer no. Then we're going to go to step number 10. Okay, so that would be back up here. And we're just going to be continuing high quality CPR, epi every 3 to 5 minutes, and considering our H's and T's. And then if we have bicarb calcium or magnesium sulfate that we consider and is indicated, we can consider putting those in. We'll talk about those more in the next video. Okay, so I hope that's helpful for you guys on the algorithm. Let's recap the non-shockable rhythm one more time. So CPR, defibrillator pads, ventilation started. Non-shockable rhythm, we're going to make it our goal to get epinephrine on ASAP. So for our next 2 minutes, right, we're going to perform CPR, we're going to get IV or IO access. And then as soon as we have that access, we're going to give a dose of epi, again at 0.01 milligrams per kilogram. After 2 minutes, we're going to again consider pulse rhythm monitor check. If it's shockable, then we're going to move over here to our shockable rhythm algorithm. If it's not shockable, we're going to continue CPR. We're going to consider an advanced airway. We're going to consider our H's and T's and see if there's anything that we can change for this patient to help them have a better outcome. And then again, we're going to consider shockable. If the answer is no, we're going to come back up here and just continue going through this algorithm. If the answer is yes, then like I said, we're going to move over here to 0.6 over here. And if we've already done our EPIs, then we can actually move to 0.8, give our amiodarone, and then continue going through it in that order. Okay, and then like I said here on our shockables, if we get our shockable rhythm algorithm, if we get an answer that no, it's not shockable, then we're now going to come over here, step 10, and we're now into our non-shockable rhythm algorithm. Okay, I hope that's helpful for you guys. We're going to do a scenario here in this video as well and kind of put this to use. We'll talk about a scenario of, okay, we have this patient, this is our presentation, how do we go down this algorithm? I'll also put up a picture here of the algorithm that's directly from AHA for you guys' reference. All right, guys, we're now going to talk about the dosing of medications in a pediatric cardiac arrest. So when we think about drug administration for pediatric patients, we know that this has a much higher cognitive load than it does when we're administering medications to adults. It also comes with a higher risk of error in administering these medications. And we want to do everything we can possible to prevent medication errors in our practice, whether it's adult or pediatric. And since pediatric medication administration has a higher cognitive load, we want to, number one, make sure we know our dosages very well, know how to calculate them, and can really just kind of do it in our sleep. But also we know that it's, some of these calculations we can do no problem on paper. But when we get into the high stress environment of a pediatric call, whether it's cardiac arrest or some other critical patient, some of that information can become a lot harder to calculate because you have so much stuff coming at you at once. So that's where something that helps us a ton to prevent medication errors is going to be having some sort of reference chart or some sort of reference source to help us calculate those dosages and to help us verify our dosages. So for my department, what I use and what I think is quite common for a lot of departments is number one is going to be some sort of pediatric reference chart. It's like a Broadslow tape or off-brand version of that. And that's going to be one of those tapes, right, that you can have your patient there, you lay it out based on how long your patient is, you fall into a category. And in that category, it gives you the medications, the dose that you should administer, the concentration and the volume that you'll administer, as well as it gives you information based on what type of laryngoscope blade should I pick, what size of endotracheal tube is going to likely be the correct size, what type of IO, different things like that. It's going to help guide you in your equipment selection as well as in your medication administration. Also can give you vitals for your patient, defibrillation dosages, things like that. And another super helpful reference that we have at the department I work with, you guys may or may not have this. It's super helpful if you guys do start carrying it. It's called HandHeavy. So it's an app that you can just have on your phone, and it allows you, whether you're en route or there with the patient, you can say, okay, I have a patient who is 5 years old. Most likely this patient will be 20 kilos. Based on that, here's my vitals, here's my equipment needed, here's my drug dosages. You can click on that and it will tell you, okay, this is the total dose, this is my concentration, this is how the volume of the medication I'm going to administer. And we're actually going to look at here in a moment something called the HandHeavy method. So the HandHeavy app, it was developed by a doctor named Dr. Antevy. And so he came up with this hand method that helps us with pediatric drug dose calculation. And it's going to be super helpful. I really like it. So we'll talk about that here in just a moment. But first, we're going to talk about the basics of what our dosage is for these medications. And then we'll talk about this rule of thumb that we can use to help us. Okay, so we talked about pediatric cardiac arrest in the last video on the algorithm. Main medications we're using, especially in our shockable rhythms, will be our epi and our amiodarone. Non-shockable, typically is our epi is our normal baseline medication. Okay, so our epi 1 to 10,000. 1 to 10,000 is the concentration we're going to be using in cardiac arrest patients, adult or pediatric. And what we need to know about this is we have, 1 milligram, 10 mLs, right? That's how it's typically supplied, 1 milligram, 10 mLs. What that means is that we have 0.1 milligrams per ml. Okay, so that's going to be helpful for us as we come over to our rule of thumb. Just remembering that each ml of our cardiac epi, our 1 to 10,000, is going to have 0.1 milligrams per ml. Okay, our dosage for a pediatric patient on an arrest is going to be 0.01 milligrams per kilogram. Okay, so if you had a 10 kilo patient, you give 0.1 milligrams, correct? Now, how often we repeat this, we're going to repeat it every 3 to 5 minutes. And then depending on your protocols, my protocols say consider stopping at 3. It's not like a hard, fast line of stop at 3, but it just says consider stopping at 3 if you see no effect. So I'll write up to 3, but just know it's not like a hard line in the sand. You can do more if it seems clinically relevant. Okay, and that can be something you can run by medical control if necessary, or just follow your protocols, whatever they say on that. So yeah, epi 1 to 10,000, it's 0.1 milligrams per ml. 0.01 milligrams per kilogram is our dosage for that. Okay. For amiodarone, again, we said this is for shockable rhythms. Our pediatric dose is going to be 5 milligrams per kilogram. Okay, and we can repeat this again every about 3 to 5 minutes times 2. Okay, so we can do 3 total doses, right? 5 milligrams per kilogram. 3 to 5 minutes later, 5 milligrams per kilogram, and then again 5 milligrams per kilogram. So it's going to be up to a max total dose of 15 milligrams per kilogram or 450 milligrams. Okay, right? We're not going to exceed our adult dosing. Adult dosing, right, is 300 and then one more dose of 150 to a total of 450. So we're not going to exceed that 450. But where it is different than from an adult cardiac arrest, right, is we're used to giving 300 amiodarone and then halving it on the next dose. We don't do this for pediatrics. We're going to do 5 milligrams per kilogram. Next dose is going to be the same dose, 5 milligrams per kilogram. And the next dose will be the same dose, 5 milligrams per kilogram. Unless, and the one exception to that rule would be if you have a larger pediatric patient. So let's say you have like a 10-year-old patient, 35 kilos, then your first dose, 5 milligrams per kilogram times 35, that gives you 175. Do that again, 175. So now you've administered 350. So now your third dose, instead of exceeding 450, going all the way up to 525 total dose, you just administer 100 milligrams, which would bring you to your max of 450 milligrams. So I hope that makes sense. But just remember, for most pediatric patients, you can do 3 5 milligram per kilogram. If they are on the larger side, just max it at a total dose of 450. And what makes it easy is a lot of times we're just going to carry 450 in our box, right, in our frontline box. So if you use all the medication you have in your frontline vials, then you're giving your max dose. Now, it might vary for you guys based on what you carry, but in my practice, that's nice, easy, kind of fail safe on that, is that we just carry 450 milligrams of amiodarone. Okay, so that's our AMI. Like I said, shockable rhythm, VFib, VTAC, every 3 to 5 minutes, 5 mg per kg. You can do that 3 times, maximum 450, or 15 milligrams per kilogram, whichever is smaller. Okay, for calcium chloride, so these are going to be some medications. We're going to touch on these 3 medications that are less commonly used. We didn't necessarily talk about them in our algorithm video. These are things that are going to be helping us as we consider our H's and T's, which the H's and T's I showed you guys in the picture from the AHA. So it's going to be your hypovolemia, hypoxia, hydrogen ions, acidosis, thrombosis, tension pneumo, cardiac tamponade, things like that. These are going to be medications that we can use to help reverse some of those problems. Okay, or at least that's our goal. That's our goal given them. So calcium chloride, we're going to give that for a patient who has known kidney failure, and we're suspecting hyperkalemia as the origin of their arrest. Okay, so calcium chloride, kidney failure, hyperkalemia. If we have indications for those, then calcium chloride can be indicated. Our pediatric dose on this is going to be 20 milligrams per kilogram. Okay, and then we can repeat that times 2 to a max of 2 grams. Okay, so typically calcium chloride comes supplied as 1 gram in 10 mLs. So you would just calculate based on that, right? We have 1 gram, 10 mLs. That means we have 100 milligrams per ml. And then based on that, you would calculate your volume that you're going to administer. Just remember, kidney failure, hyperkalemia, if you suspect hyper-K as your origin of arrest or your etiology of the arrest, then this is a good medication to administer, 20 milligrams per kilogram, times 2, so you can do 3 total doses up to a max of 2 grams. For sodium bicarbonate, typically, right, this comes in adult, ampule is 8.4%, and then pediatric is 4.2. And pediatric, when I say 4.2, that's going to be less than a year. So that'd be more of like our infant would be 4.2. So any patient above 1 year old, we're going to use just the standard 8.4% solution. Any patient less than that, we're going to use the 4.2. Our dose on it is going to be 1 milliequivalent per kilogram to a max of 50. And again, refer to your protocols. This could be different for you guys on your protocols on your max dose. That's what mine say. And the other ones I've referenced say max of 50, but just know that could change. But just remember, 1 milliequivalent per kilogram, it's going to be your standard dose. And then we know that in our 8.4 solution, typically that's going to come 50 mLs with a 1 milliequivalent per ml. Okay, so that'll be helpful for us when we talk about our hand-heavy method over here. But just remember, 1 milliequivalent per kilogram up to max of 1 ampule, 50 milliequivalents, and it's going to come in 1 milliequivalent per ml, typically. If it's the 8.4% solution, then it will. Okay, and then finally, mag sulfate. So this is going to be for your patients with polymorphic VTAC. So this is going to be like your torsades or some other sort of polymorphic VTAC. For those patients, magnesium sulfate is going to be indicated for these patients. And we know that our adult dose is going to be 2 grams pushed over 2 minutes. For a pediatric patient, it's going to be 50 milligrams per kilogram up to 2 grams over 2 minutes. Sorry, it's kind of small there, but 50 milligrams per kilogram, max of 2 grams, and we're going to push it over 2 minutes for a torsades or a polymorphic VTAC. Okay, so that's our basics in our basic drug calculations or drug dosages there. Let's talk about a couple other things before we move over here to our hands-heavy method. So when we are thinking cardiac arrest, let's actually move down here to defibrillation, then we'll come back up to the endotracheal tube formula. For defibrillation in pediatric patients, our dose is going to be 2 joules per kilogram. Okay, and then we're going to escalate each dose, so increase dose by 2 joules to a max of 10 joules per kilogram. Okay, so like I said in the last video, I believe I briefly mentioned it, is you have your 2, 4, 6, 8. That's how we defibrillate to a max of 10, right? So 2, 4, 6, 8, 10 joules per kilogram. And that's how you're going to calculate it, right? So if you had a 20 kilo patient, you're going to start at 40 joules, go up to 80 joules. And then let's see, 6 times 20 would be 120, 8 times 20, 160, and 10 times 20, 200. So that's kind of how you'd escalate your dosage. Most likely, right, you're not going to go above 200 joules on your max dose. I know my equipment that I use won't go above 200 joules on normal defibrillation. So you're going to just go up to that max of 200 most likely. Again, refer to your protocols on that. Also, something to note is a lot of your equipment, like if you guys use a Zoll monitor, it's not often really going to let you do like a precise like 176. You know, you're probably gonna have to choose the closest one. That's going to give you maybe 180 or 175, something like that. So just get as close as you can, right? But this is going to get you right in the precise dosage, and then you're going to have to choose the closest one that your monitor will allow you to administer. Okay, so just remember 2 joules per kilogram on your defibrillation dosages, escalating by 2 joules per kilogram up to a max of 10. So 2, 4, 6, 8, 10, or 2, 4, 6, 8. That's how we defibrillate. And just to know, AHA, it says to go, start at 2, go to 4, and then you can go all the way up to 10. It doesn't necessarily say you have to, right? My protocols are just written, do it, right? Just go 2, 4, 6, 8, 10. So again, that's a refer to your protocols thing, but just know that AHA doesn't necessarily say you have to go up to 10, but it's just you can make sure you start at 2 joules per kilogram. Second dose should be at least 4 joules per kilogram. And then from there, you can at least stay at 4 joules per kilogram, or you can continue to go up. Okay, let's talk about our tube formula real quick. So this is how we can, based off the age, calculate the size of endotracheal tube that we need. You're going to see one formula that says age plus 16 divided by 4. It's a good formula, but it's not quite as precise as the ones I'm giving you here. The ones I will give you here are going to help you. You have a formula for cuffed tubes and a formula for uncuffed tubes. Okay, so for your cuffed tubes, you're going to use the formula. It's going to be age in years divided by 4 plus 3.5. Okay, so age divided by 4 plus 3.5. So if you had a 4-year-old patient, right, take 4 divided by 4, they give you 1 plus 3.5. You'd want a 4.5 cuffed tube. For your uncuffed tube, it's going to be same thing, age divided by 4, but now you're just going to add plus 4, right? You just want a slightly bigger tube if you're using uncuffed. So then for a 4-year-old patient, right, it'd be age divided by 4. You get 1 plus 4, that'd give you a 5.0 uncuffed tube. Okay, so just remember that formula there. Again, if you have a reference charts like Hand Heavy or a Braslo, it's going to give you those numbers of what size tube. But this is a really good thing to know. It's just, okay, we got a 3-year-old patient or a 4-year-old patient, right? Age divided by 4, 1 plus 3.5 is the size of cuffed tube I'm going to use. Okay, so that's our medications over there. Let's briefly talk about this Hand Heavy method. So this is a really nice rule of thumb, for just a quick rule of thumb of calculating our volume of medication we're going to administer to these patients. And we're going to see that obviously if you give the right volume, you're going to be given the right dose. So how this works is we have kind of the hand right here, right? And on our hand, we can say, okay, thumb is 1-year-old patient, 3-year-old patient, 5-year-old patient, 7-year-old patient, 9-year-old patient. We know that most standard 1-year-old is going to be 10 kilos, 3-year-old 15 kilos, 5-year-old 20 kilos, 7-year-old 25 kilos, 9-year-old 30 kilos. Okay, so those are just going to be your standard weights based on age. And then using this method, we can quickly calculate the medication volume that we're going to administer to these patients. Okay, so on the Hand Heavy method, and I'll cite the sources in the below so you guys can find it, but it has a bunch of medications that we can administer. I've gotten the ones that are most pertinent to us for pediatric arrest. So kind of what we're going to see is I'll explain it to you guys here on our 1-year-old patient, and then we'll take a brief look at the other ages. So we see that we have epi 1 to 1,000. That'd be more of our anaphylaxis epi. Epi 1 to 10,000. That's going to be our cardiac arrest epi. Our amiodarone, our bicarb, our D25Ws or our D25, right? So our dextrose 25, and then normal saline, so our fluid bolus. Okay, so we know that for epi 1 to 10,000, 1 to 1,000 anaphylaxis is going to be 0.01 milligrams per kilogram. And then we know that we have 1 milligram per ml. So we know that for a 10 kilo patient, right, we're going to just take their weight and we're going to move the decimal point over It should be 3 over twice, right? So we take the decimal point, we go 1, 2, then that gives us our dose. The nice thing is, especially as we're looking here at cardiac arrest, that's a nice one to know, but it's especially focusing in on these two medications, our epi and our amiodarone, is it makes it super simple, right? We have a 10 kilo patient. That means we're going to just move our decimal point over to 1, and that gives us how many mLs we want to administer, right? And we said, so 10 kilo patient at 0.01 milligrams per kilogram. The dose that we now want is 0.1 milligrams. Remember that we have 0.1 milligrams per ml, so that comes out correct, right? We administer 1 ml, and that gives us our epi dose, which would be 0.1 milligrams. Nice thing is, if we can look at this, we go up here, right? A 3-year-old patient at 15 kilos, we're going to administer 1.5 mLs because we want to give 0.15 milligrams, 0.1 milligrams per ml, 1.5, 0.15. Okay, and the really nice thing is that we see that amiodarone actually comes out to the exact same volume that we're administering for these pediatric patients. Because amiodarone is supplied 150 and 3 mLs, right? So 50 milligrams per ml. So if we want to give 5 milligrams per kilogram to a 10 kilo patient, that means we want to give 50 mLs. So if we give 1 ml, 150 and 3, 50 per ml, spot on, right? And this works up here as well. If we want to give 5 milligrams per kilogram to a 15 kilo patient, we want to give 75 milligrams. If we take 1.5 mLs, just move that decimal point over 1, then we get 1.5 mL, so at 50 milligrams per ml, we get 75 milligrams. Okay, we're going to see that tracks all the way across the board just based on our weight. Super nice. So that's a really nice takeaway, is that our volume of epi and amiodarone is going to be the same that we administer on a cardiac arrest patient. For our bicarb, we said that we want to give 1 mil equivalent per kilogram, and we have 1 mil equivalent per ml. If we're giving 8.4 or 8.4%, that makes it nice and easy. Whatever your kilogram weight is what your mLs is going to be that you administer. If we have a hypoglycemic patient, which would be one of our H's and T's, right, hypoglycemia, then we're going to want to administer dextrose, right? So if we're using D25, nice rule of thumb, right, is that we just take our kilograms and we multiply it by 2, right? Because our dose is going to be 2 mLs per kilogram. So that just makes it very easy, right? We give 20 mLs. If we have a 15 kilo patient, we give 30 mLs, etc. And then for our fluid bolus, we know that our typical dose is 20 mLs per kilogram. So if we take our weight, multiply it by 2, and then or by 20. It's the simple way to put it, right? Multiply that by 20, you get your 200 mLs. So let's take a look, right? So our 10 kilo patient, 1-year-old patient, we're going to give, in a cardiac arrest situation, 1 ml of epi, 1 ml of amiodarone for each dose. We can give 10 mLs of bicarb would be the correct dose, 20 mLs of D25, and 200 mLs of NS. Look up here at a 33-year-old patient, 15 kilos, be 1.5 mLs amiodarone, 1.5 of epi, bicarb, 15 mLs, and then we have these dosages here, okay? And then we look over here, 5 years old, 20 kilos, epi is 2 mLs, ami is 2 mLs. If we need to do bicarb, it's 20 mLs. And then we have our other medications. 7-year-old patient, 25 kilos, epi 2.5 mLs, amiodarone 2.5 mLs, bicarb 25 mLs, other medications. And then 9-year-old, 30 kilo patient, epi would be 3 mLs, amiodarone's 3 mLs, bicarb would be 30 mLs, and then our other medications. If we do the math on that, right, so if we say, okay, 30 kilo patient, we want to give 0.01 milligrams per kilogram, we want to give 0.3 milligrams to this patient. We get 3 mLs at 1 or 0.1 milligram per ml, then it comes out to the correct dosage. So this is super helpful, guys, and it's very easy to remember, right? You have 1-year-old, 10 kilos, 3-year-old, 15 kilos, 5-year-old, 20, 7-year-old, 25, and 9-year-old, 30. And then just remember, especially for those 2 main medications in your cardiac arrest, right? Then just remember, okay, whatever my kilograms is, move the decimal point 1 to the left. So if I'm 30, move it over 3, 25, 2.5, etc. And that gives you a very quick volume calculation of what you should be administering to these pediatric cardiac arrest patients. Okay, guys, I hope that's helpful for our drug dosing for cardiac arrest. Okay, so actually one more thing I wanted to touch on medications is, we're not going to go in depth on ROSC in this video. We don't have time for that, but I just wanted to touch on our push dose epi dosage for pediatrics. That way, when we're thinking about ROSC and we need to manage our BP, get them up to where they need to be, we know what this dose is. So our push dose epi, we're just going to talk about this real briefly, is typically going to be 1 microgram. 1 microgram per kilogram. And then typically it'll be a max of 10 micrograms. So really most patients you're going to be given 10 micrograms to. And then you can do this every 3 to 5 minutes. And typically you're going to do this after you've given a fluid bolus in an attempt to bring up their BP. So just know that 1 microgram per kilogram, max of 10 micrograms every 3 to 5 minutes. All right, guys, well, that wraps up our lecture today on pediatric cardiac arrest. I hope today's lecture was beneficial for you guys. I hope there's information that helps you guys progress your knowledge in knowing how to treat pediatric arrests, and it's something that's going to help you in your practice. I did mention at the start of the video that I was hoping to perform a scenario demonstration for you guys, and I actually did get a video shot of it, but unfortunately the footage corrupted, and due to all the logistics that went into shooting it, it was a lot of work to coordinate it with my crew and all that. We weren't able to do it again, so I was unfortunate that it corrupted. I'm sorry I couldn't show that to you guys, but what I would recommend is take this information that you guys have learned and get your crew together and do a practice cardiac arrest scenario, right? There's only so much good when you have the head knowledge of doing it compared to taking the head knowledge and putting it into the mechanical, actually performing it. That's what's really gonna make it stick. So I'd highly recommend take this knowledge, teach it to your crews, and then go perform a pediatric cardiac arrest on one of your mannequins, and just really get that muscle memory. That way, in the scenario that you guys do respond on a call like this, you're gonna be ready. Okay guys, I hope this is helpful. Thank you for watching. Have a great day.